and I'm coming to you from CNM to talk about E&M coding in 2024. As we look at E&M coding, or evaluation and management coding, it has changed a lot over the last couple of years. So today's video is for this year and any years going forward as we look at evaluation and management coding and the current guidelines that went into effect officially starting in 2021 and 2023, as well as the changes in 2024. So let's get started. This is going to be a three-part lesson. So this week we're focusing on what is an E&M code, how do we select our E&M section, and what information is relevant when we're looking at the criteria for our codes. I'm going to go ahead and share my screen here as we get started on this. Okay, so the first thing we want to look at, I'm going to be using a couple of resources this week. We're looking at our E&M coder with HCPCS and CPT Finder from 3M, which is part of the AHIMA VLab technology and resource tool. If you don't have access to this, do not worry. But we're going to use this in order to kind of go over how we select E&M coding. Our secondary resource is going to be our Bucks step-by-step medical coding, chapter 11 for evaluation and management services. And then finally, we're also going to be looking at a couple of external resources that I will make sure to have available for those of you in my class. The first thing we have here is our chapter information from Carol Bucks. Evaluation and management services. You have a couple of things we're going to be focusing on this week, which is the contents of the E&M, what factors go into the E&M selection, and basically how to select those factors with office and other outpatient codes. When we go into more depth about this, we'll talk about medical decision-making and how it actually goes into selection versus time. Today, I want to talk to you about what is an E&M service itself. So the first thing we're going to pull up is an actual note. Let's look at this office visit. What do you see? A couple of things that might pop up, of course. You have a chief complaint, which is your primary reason for the patient being seen. This is in the provider's own words, so sometimes this may change throughout the course of the provider documenting, but the patient will schedule an appointment, and when the provider determines what is their chief complaint, what is the main reason for their visit, they're going to put that here. A lot of times your nurses may also contribute to that portion of the note, and the provider just pulls in the information from the scheduling. Our HPI, or history of present illness. This is meant to look at the complaint the patient is coming in for today and say, based off of their chief complaint or complaints, these particular items were present, are the present illness, and this is the history of that illness. So for this particular example, we have a patient with multiple chronic conditions, not uncommon, and they're coming in with history of those chronic conditions. So they're telling us, well, what are they? In this case, we have emphysema, hypertension, and quote unquote liver spells, which would be the patient's own words of what they're going through today. An ROS, or review of systems, is also in here. So your review systems or symptoms are going to review any conditions related to those chief complaint or history of present illness factors. So here we have, for emphysema, hypertension, and liver spells, we have symptoms for shortness of breath, information about that, so it's getting worse. They're asking the patient about cardiovascular conditions like chest pain. And then they just kind of said, well, we got frequent liver spells of fatigue and poor appetite. So just kind of an overall talking about daily living, that they're being tired and they're not eating well. Other parts of your history include things like your social history, your medical history, and not documented in this visit, but also family history. So let's talk a little bit about history for a second. What is relevant when going to the doctor? If you're like me and you go to the doctor and they want to know every single detail about you, you might sit there at times and wonder, gosh, I don't even tell my spouse this. But it's very important when you're talking to your doctor to give them as much information that may be related because doctors know what to specifically look for that might be related to, say, emphysema or hypertension, whereas we as patients don't always think of these things. So, this is why they ask us for specific information in our social history, like do you smoke? Do you drink? What kind of sexual uh, happenings do you have on your in your life? And so they'll go over all of those kind of things here. Your medical history is more specific. Have what conditions do you have or how long have you had these? So in this case, well, I have hypertension, it's controlled, and I have emphysema. I've been diagnosed with those. Those would be medical history. Same thing with family history if it were documented, but it would just simply say mother or father. So I could actually point out some family history by saying family history includes a sister who smokes, although it sounds like because of the secondhand smoke, they wanted to put that under social history. Okay. So all four of these, our chief complaint, our HPI, including the ROS, our social, medical, and of course, when documented, family history are all part of what we call the history component of the visit. This is all information that the patient is answering that tells us a little bit about, the story of who they are. If you think of your office visit, the next thing you might think of is when the doctor says, "Okay, go ahead and hop on this table here or this bed and let me listen to your heart, let me look at various things." This is called the exam. This is the actual physical part of your evaluation and management code. Your exam has some of what we call observational and physical elements. So physical elements are things like collecting blood pressure, patient's pulse rate, and oxygen status. They put the machines onto you, and usually this is done by an MA or a nurse prior to the patient seeing the actual doctor. This is, however, reviewed by the doctor, usually before they go into the exam room with you. Other things like observational, you have abbreviation here for constitutional. So constitutional just means like overall, how did they look? Did they look sickly? Did they look happy? In this case, you have a slightly overweight female, but not in distress. So this is something that they observe, and we do this to each other. It's on a daily basis. We observe things about each other. Hey, you look well. Um, that kind of information is very specific to your constitutional, um, your head, ears, eyes, nose, and throat. Um, Atraumatic, norma, cephalic. Normocephalic. I like to refer to these terms as, your head was on your head and it looked normal. It didn't have any problems. So if they had problems, then they would not use this term. I highly recommend practicing saying those words 3 times fast and pulling up in your medical dictionary if you're not familiar with anything in your exam portion. And the reason I say this is because it's very important that new coders understand each area and why it is being listed so that you can identify when something is unique and not normal. Your perla is looking at your eyes specifically, looking at the whites of the eyes, looking at the iris, seeing just kind of, again, this is observational, but they may go a little more in depth. You'll notice they mention jaundice of the sclera. So what does jaundice mean? You want to look up these terms if you're not familiar. Oral mucosa is clear with no signage drainage. Again, if you're not familiar with the terminology, this is a great refresher into med-term. And you'll notice that they're going kind of from overall head downwards. So your next one being the neck, and they're just kind of, this would be the feeling of the neck. They're saying it's supple, so it's palpable. There's no carotid brute. The chest has a slight increased effort. There's no barrel chest. It's clear, no crackles or wheezing. Gentle, not genital urinary, that's down here, gastrointestinal. And again, if you're not familiar with these, just go ahead and pull them up. It's okay to get them wrong. It's okay to review it 6 different times. Trust me, I do review a lot of terminology every time I'm coding notes, just because I want to make sure I'm fresh and that I have all of the accurate terms in my head. So this is talking about just kind of the exam, the physical exam into the stomach. There was some hepatomegaly, otherwise no organomegaly. Bowel sounds were normal, so that's what that BS stands for. You know, you thought I was going to say something else. Genital urinary was deferred, meaning that they did not do a genital urinary exam. Musculoskeletal moves all extremities well. That's something they can observe. Skin, there's no visible lesions, no concerns voiced when questioned. And so that statement kind of should have been up here in the review symptoms, but that's perfectly fine to put it here. They're just kind of observing the skin and saying that I don't see anything wrong with it. And so all of these are called exam elements. Now, the beautiful thing, and I'm here to tell you, is you don't have to worry about which elements are used. If you've ever heard the term 95 or 94 guidelines, we used to look at all of those little bitty details. And the current guidelines for 2024 evaluation and management simply say an appropriate history and exam should be on the note. So as long as your provider is documenting appropriately what they look at, what they talk about with the patient, and it gives a good history and a good exam that would be necessary for the patient's concerns, you are perfectly fine with whatever amount of detail is there. Just make sure that you understand it, because you are looking for things later on called medical necessity, and we will talk about that in a future video. The last part of your note is your assessment and plan. Sometimes this will be in a separate area. This is where we find our diagnoses and our treatment. So when we assess the patient, we're going to determine with whatever availability that we can, what is going on with the patient and what would be the best process of treatment at this time. So here, you'll notice some of these things pulled from the exam. So everything should support each other. Hepatomegaly, we know that they documented hepatomegaly here under GI, but if they had said none, that's an area where a coder should question. We're uncertain significance, so we don't know if that's important or not. It does not appear to have significant workup. It needs established diagnosis. So they're saying, I don't know what this is. I need to do some workup to find out. And then the workup they're going to do, they're doing a screening blood work for hepatitis C is ordered. So that's a lab. And then if it's positive, we're going to do additional testing. So this is the testing they're saying, hey, let's do the screening first. And if we need to, we'll do additional genotyping, which is a more expensive lab test. Until I find that out, though, I don't know the prognosis. And so we'll need them to come back, obviously. You have hypertension. Hey, they did mention it here. They reviewed it and they reviewed the medication here. And they're just saying basically continue it as doing, but there's a new prescription being sent to the pharmacy. I disagree with this statement. It's actually an established prescription that the patient has had, unless this patient is new. In fact, this patient is. So we'll talk about new here in just a moment. So this is a new prescription because the doctor is newly prescribing it for this patient. And so they're putting that in there to support their medical necessity. They're planning to bring her back and make sure that, you know, the medication is in fact where it should be. And then the emphysema, which seems to be more the primary purpose of the visit here. She does not wish to take steroids. She's out of the smoky environment, so she's not around her sister's smoke. They're gonna reevaluate later, but they're gonna order a chest X-ray to kind of get a good idea of where she's at. That's what a baseline is gonna tell them. Okay, so all of that information, ooh, it's a lot, right? Not to worry. We have a lot of tools and resources to help us understand exactly what is going into our notes so that we can make the most appropriate code for this visit and so that we can honor our provider's time and the amount of energy it took for them to provide this service to the patient. Now, your next video, we're going to talk about different types of service and how to determine the criteria. I'll go ahead and close this one off. But for an overview of what are E&M codes and what goes into it, what did you think? There's a lot of information. Luckily, we don't have to code everything that goes into the note, but it is always good to remain on our toes. We'll see you in our next video.